Hello, my name is Sonia Carlson and I am a PGY3 at University Hospitals. Today I will be talking about patient predictors of compliance rates after implementation of an enhanced recovery protocol. The Enhanced Recovery Protocol is a multimodal surgical pathway that was developed by a multidisciplinary team of surgeons, anesthesiologists, pharmacists, and nursing staff. An enhanced recovery protocol typically includes preoperative elements, intraoperative elements, and postoperative elements. Enhanced recovery protocols have been shown to decrease opiate use, decrease PCA use, decrease morbidity, increase patient satisfaction, decrease hospital length of stay, and decrease hospital costs. There is data regarding compliance rates of enhanced recovery protocol within the colorectal surgery literature. However, we don't know a lot of this data within gynecologic surgery. What we do know are mostly found within gynecologic oncology patients. They only evaluate a subset of the components of an enhanced recovery protocol, and they typically only analyze small cohorts of patients. So our objectives were to evaluate percent compliance with a newly instated enhanced recovery protocol and to identify patient predictors of enhanced recovery protocol compliance. We performed a retrospective observational study of women between the ages of 18 and 89 years old who underwent a hysterectomy for benign indications from January 1st, 2018 to June 30th, 2018. We included minimally invasive modes of surgery, including robotic-assisted laparoscopic hysterectomy, total laparoscopic hysterectomy, and a vaginal hysterectomy. Exclusion criteria included emergent indication for hysterectomy, previous hysterectomy, and repeat hysterectomy after a failed first attempt. We initially reviewed 305 charts, and after excluding certain patients based on our exclusion criteria, we had 154 participants included within our study. Our primary aim was to look at compliance measured as a percent utilization overall with enhanced recovery protocol, and then also within each of its preoperative and postoperative components. Our second aim was to identify patient predictors of enhanced recovery protocol compliance. Our enhanced recovery protocol included preoperative components and postoperative components. Within preoperative elements, we had pain control and oral intake. For pain control, we looked at whether these medications were ordered preoperatively or if none of them were ordered. And then for oral intake, we looked to see if the patient was allowed fluid intake up to 7 hours prior to surgery. Within the postoperative elements, we looked at IV fluids, pain control, bowel regimen, activity, and oral intake. For IV fluids, we looked at an order to discontinue OR fluids before going up to the floor, IV fluids set at 40 mL per hour, trigger order for peripheral lock IV. For pain control, we looked at scheduled Tylenol and NSAIDs as well as oxycodone PRN if they had no medication ordered or if they had no PCA use or PCA use. We also made sure they had a bowel regimen. We looked at activity, out of bed activity by postoperative 1. And then we looked at oral intake, which includes a regular diet by postoperative day 1 and at least 800 millimeters of oral intake by postoperative day 1. These are some of our patient characteristics. The mean age was 46 years old. Our average BMI was 34. Our patients were either mostly African American at 58% or white at 40%. Our ASA score was usually 2 or 3. Current smokers, we had about 25%. For prior abdominal surgery, 68% of our participants. About 37% had hypertension, 10% with diabetes, and 23% with chronic lung disease. This figure 1 shows preoperative overall enhanced recovery pathway compliance. So our overall compliance within the preoperative component was 66.9. Our compliance rate for administering any of the pre-op meds was between 55 and 65%. And then allowance of oral intake up to 7 hours before surgery was the lowest compliance out of all the preoperative components, and that was 45%. This figure is looking at postoperative enhanced recovery protocol compliance. We found that overall it was higher than the preoperative elements at 77.9%. Compliance with protocol elements that dictated management of IV fluids, bowel regimens, and postoperative pain control ranged from 76 to 96.8%, which was overall pretty high. And of note, we had zero PCA use. Overall, thinking about our compliance rates, our lowest compliance was within the preoperative elements of the pathway and was specifically when we looked at allowance of oral fluids up to 7 hours prior to surgery. This is interesting because traditionally fasting was recommended due to the known risk of aspiration pneumonia, secondary to general anesthesia effects on the laryngeal reflexes. However, newer studies have showed that preoperative carbohydrates up to 6 hours may actually reduce postoperative insulin resistance and improve patient comfort with faster postoperative recovery. Another interesting look at our compliance rates was that it was high and comparable to the other studies on compliance with enhanced recovery protocols in the colorectal surgery literature, and it was consistent within the 6 month period that we looked at, between 70 and 75%. When we looked at our patient predictors, we found that age less than 50 years old, Black non Hispanic patients having surgery for abnormal uterine bleeding and having surgery for pelvic pain were often associated with increased compliance of our enhanced recovery protocol. Some of the limitations in our study is regarding documentation and some aspects of the protocol. Specifically, when we looked at participants that had 1+ deviation from the protocol, only 10 of them had a documented reason in their chart. So, for example, if it's because of medication allergies or the patient declined a certain intervention, it just wasn't clear in the chart what the reason was. 54% had deficient documenting in timing preoperative fasting. So this wasn't clear from the anesthesia records in all of our patients when exactly the preoperative fasting time started. And then about 42.9% were deficient in documenting postoperative oral intake. We also performed a single center study, so a multi-center trial would be interesting to look at to see if their compliance rates were similar to ours. Future studies would be interesting in looking at barriers to compliance to see if we can increase further compliance. So if we can figure out what barriers are our nurses, anesthesiologists, surgeons, and administrative staff that discuss cases with patients the day before in terms of compliance, then we can figure out ways to have interventions that can increase compliance rates. I want to thank and acknowledge these individuals for helping me with my project. I want to thank you for taking the time to listen.